Thank you very much for the introduction, and thank you for organising today's meeting. So I'm going through septal deviation with you, and it's nice to see so many of the authors of so many of the papers on septal deviation in this audience today. So I'll start with going through just some brief anatomy. The septal is composed of cartilage and bony components, the quadrilateral cartilaginous part, and then the perpendicular plate, the ethmoid, the vomer, the palatine bone, and the maxillary crest. So we have a sagittal section and the cross-sectional area there, which is what we're looking at when we're looking at studies. When we look at patients with septal deviation, it's a huge reason for patients to come and see us as ENT practitioners, and what we really need to do is to work out which of these are clinically significant and which of these we should be operating on and which of these may not need surgery, and that's something that I think still needs to be answered. The prevalence of septal deviation depends on the study you look at. It varies from around 20% to 65%. Part of this is because of the different criteria used in the definition. So one study describes it as a greater than 4 millimetre from the midline deviation, whereas another will be describing it as a mild, moderate or severe deviation. So with no standard criteria to determine when a septal deviation is clinically relevant, it's very difficult for us to go ahead and plan our surgery for this. Symptoms associated with septal deviation are common, and all of us as ENT surgeons are used to seeing them. Chronic nasal obstruction, sinus pain and pressure, crusting, rhinorrhea, snoring, epistaxis, and reduced sense of smell. Sometimes septal deviations are easy to see. This is one of the England rugby players with a very obviously deviated nose, and he's married to Zara Phillips, Princess Anne's daughter. There was some discussion on whether he should have his nose fixed before the wedding, but it was waiting until his rugby career was over. It was the deciding factor for him. And as you can see, that's an easy deviation for us to pick up. However, most of the ones we see in clinic are not quite like this. And externally, we may see a normal nose, but what we need to know is what on the inside will interpret or guide how we operate. Areas of the nasal cavity. Well, we need to know how we're going to classify where the deviation is. And there have been a number of classification systems over time on how they've done this and which areas are important in the deviation. This goes back to Cottle's original classification of it, where you have the nostril, the nasal valve, the attic area, anterior aspect of the nasal cavity, and then the posterior aspect. But more recently, there have been a review of all the studies looking at classifications of nasal septal deviation, and they've come up with 5 different areas that they think you can classify your septums as. So what they looked at is on anterior rhinoscopy and nasendoscopy. They describe the deviations as either being cephalocaudal or anteroposterior, and whether it's a C-shaped deviation, an S-shaped deviation, a spur, or anteroposteriorly a C-shape or an S-shape. And obviously all of these things will have different impacts on how the air flows throughout the nasal cavity. In clinic, we ask patients to go through their symptoms for us, and we use the nasal outcome and septum evaluation score. And this is 5 questions where they're scored out of 4 each, and this is multiplied by 5 to give them a total nose score. And we describe the obstruction as being either mild, moderate, severe, or extreme, depending on how patients score their nasal symptoms. However, this is only an idea of how we can manage it. There are a number of objective tests out there, but unfortunately with these, they don't always classify where the deviation is, how severe it is, or what impact this has for us. So as a clinician in a busy clinic, particularly in the NHS, in a government healthcare system, we don't necessarily have available to us acoustic rhinomanometry, and even doing imaging for septal deviation would be something that would not be supported within our NHS system at the moment. So to go forward with CFD on septal deviation would be something that we would be doing for research purposes and would need to guide how we're going to evaluate noses in future. We use visual analog scores and nose scores regularly. There's an interesting paper back in 2002 by Eccles and Roblin, what, if any, value is septal surgery? Having spent a year working for Professor Lund at the Royal National Throat, Nose and Ear Hospital, she doesn't believe in septal surgery at all. She doesn't do a septoplasty. So it's an interesting concept compared to the majority of my colleagues who agree that there is benefit and we should be doing it. But we need to have a classification of why we're doing it and when we're doing it. So the controversies in septal deviation: what is our criteria for diagnosis? How do we classify the site and the degree of deviation? Is there any correlation between subjective and objective measures? And what outcome measures are we going to use going forwards? And how can CFD help us with this? Can it help us? And what can it guide us with? So the questions we're looking at, can we identify which deviations are likely to be clinically significant using CFD? There have been a number of papers on septal deviation and CFD studies throughout, going back over 10 years. They are based on a very small number of patients and only a few scans. If you count up the total number of patients with deviation there's only around 30 patient studies we've looked at, which, when you're looking at changing practice for a generation of rhinologists coming through, I think we need to have larger numbers or better classification of our deviations. One of the first studies, back in 2008, looked at septal deviation of concha bullosa and their effect on nasal airflow. And this was a CT scan that was taken from a cadaveric model. And if you look on the right-hand side there, you can see the top coronal sections at points 1, 2, and 3 show the nasal septal deviation with the concha bullosa, and the lower one is post having virtual surgery. And the airflow or the velocities have become much more uniform between the nasal cavities on both sides. But this is one case, it's a cadaveric study, and will this apply to our clinical work? They did find that the virtual surgery reduced the nasal airflow speed, and the airflow through the right middle meatus was increased. Another study we've already heard about earlier from Professor Chen, who nicely showed this with the MRI scan on the left showing normal anatomy, and on the right we have the septal deviation, and you can quite clearly see the difference in the velocity magnitudes as we look at the nasal cavity. Going forward, we've got Professor Garcia here, who's done a lot of work on septal deviation. In his study, he looked at the septal deviation in the nasal passages and their effect on resistance. He'll also has talked to us about the rhinomanometry and the studies with rhinomanometry. We looked at one patient's CT scan, and they used a computer-aided design package to change where the deviation was within the model. That created 9 different models to determine which are the most important points within the nasal cavity for that septal deviation to be and that impact on the nasal resistance. So looking at the original geometry at the top, it's quite uniform. They put inferior deviations, middle deviations, and superior deviations, and looked at them in the anterior plane, the middle plane, and posterior plane. And from the results, they showed that the greatest nasal resistance was when there was an anterior inferior nasal deviation, which is what we would expect clinically, but we didn't have the information to back that up. The next studies looked at 15 patients with septal deviation, so more patients being involved each time, but the way we've classified it here again is slightly different again. There are 4 healthy volunteers, and we divide the deviations into whether they're caudal, anterior, or medial, and look at the different flow patterns through the nose with each. What came back from the results of this study was that the caudal deviation had the most impact on the flow dynamics within the nose. More recently, Kim et al. Have looked at 6 anatomically accurate models of the nasal cavity with septal deviation. 3 of these patients had symptoms and 3 were asymptomatic. So these are patients with septal deviation but are not having any problems at the moment. So it's interesting to see, is there a difference you could pick up between the 2 groups? And if you look at the non-symptomatic patients, these are the top 3 scans, you can see some of them have got quite obvious nasal deviations. And looking on a scan alone, we would not necessarily know why they're asymptomatic. What they came up with and what was interesting from their results was that in the symptomatic cases, the pressure drop was seen to be larger, the flow was more uneven, and the local maximum velocity and more shear stress was seen to be higher. Whether this will bear out with further studies and bigger results, we're yet to see. But it does seem that we can identify some features of nasal airflow obstruction from CFD and the scans that we may not be able to pick up clinically. What we need to know is, could the factors related to this be, and the elements found on CFD, be useful in patient objective diagnostic tools going forward? So in conclusion, CFD methods can investigate the airflow patterns in septal deviation. They study the patterns and help us better understand the clinical significant ones. However, our knowledge at the moment is based on a very small number of cases, and how we apply this to what we do surgically, I think we're a way away from as yet, but I'm happy to be corrected. I look forward to questions.